something that you don't feel is necessary to provide cultural competent care. And again, there's no right or wrong answer for this, again, just to raise some awareness and some issues to how to provide better cultural care. Individuals tend to score higher on awareness and sensitivity than behavior, and sometimes behaviors do not reflect perceived levels of cultural competence. So do you think yours do? Prior research has shown that healthcare providers tend to perceive themselves at a higher level of cultural competence than their behaviors reflect. So we're trying to kind of bridge that gap. So even though we as athletic trainers perceive ourselves as culturally competent, maybe our behaviors aren't necessarily reflecting that higher level of cultural competence. Again, just remember that these are just a few pieces to the cultural competence assessment. So now that you've had some time to think about various statements on cultural competence, how do you feel? Do you believe yourself to be more culturally competent? Have you identified areas of cultural issues that you believe you should consider when providing care? Again, the purpose of this exercise was just for you to identify a few techniques that you may be able to utilize in your documentation or in the behaviors when you're interacting with your athletes and patients. So in conclusion, back to that first slide we talked about, cultural competence is an ongoing, ever-changing process. One never totally becomes culturally competent. It's going to be a continuum. You're going to continue to work towards that higher level of cultural competence. So how do we do that? Well, to continue to educate ourselves on issues affecting the populations that we serve. So purchase or review educational materials on cultural competence or special needs populations within healthcare, attend cultural enrichment events, provide service to unrepresented or underserved populations, and enroll in diversity training. Remember, someone doesn't need to look cultural to be cultural. And just because you identify somebody as being in the same cultural group as yours, there may be differences within that all cultural group. Just by watching this video, you become more aware of cultural issues by identifying yourself and the population that you serve. So in conclusion, when healthcare practitioners possess more knowledge and respond with sensitivity to cultural issues, optimal outcomes are achieved. And with culturally competent care, athletic trainers can provide the optimal healing environment for the athletes and patients we treat. Throughout the remainder of this video, you will learn more about the statistics and specific healthcare concerns of the physically active population we treat, and you'll also get to explore how healthcare differs from culture to culture and learn some strategies to improve the service to culturally diverse individuals. Thank you for your time.
Session 3, Conducting a Culturally Based Physical Assessment, will be presented by Renee Revis-Shingles.
Hello, my name is Renee Revis-Shingles, and I'm the Associate Professor and Director of the Athletic Training Education Program at Central Michigan University. Today I'm going to talk with you about conducting a culturally based physical assessment. When conducting your assessment, it is important to think about the evaluation process and what happens when you are doing an evaluation. It is important to gather information that is pertinent, that is accurate, and realizing that miscommunication can occur even when there are differing cultural conventions. Also, you need to realize that miscommunication can occur and lead to incorrect diagnosis, inappropriate care, and non-compliance. And certainly as athletic trainers, we want to be able to gather appropriate information. So, developing good evaluation skills, you know that it takes time, it takes energy, and it takes commitment. So does providing culturally competent care. When evaluating our patients within a cultural context, it really helps the athletic trainer to gather more complete information. And it also conveys to your patients that you care about them. You care about them as a person and not just the body part that is walking in. How many times have you said, "There goes my ankle patient," and I imagine this little ankle walking by with a nose on it, as opposed to the whole body that comes into the athletic training room. So we have to remember that culture is always present and that it operates and it influences the interchange in every evaluation that we do, whether we're between cultures or whether we're within culture, whether we're on the same cultural page, in the same cultural book, whether we're culturally congruent or incongruent, culture is going on. So throughout this presentation, what I'm going to do is take us through the evaluative process, the history, the inspection, and the palpation, and what are the things that you need to consider as an athletic trainer when you are evaluating someone within a cultural context. So we'll start with the oral history, specifically looking at communication. And our first is going to be non-verbal communication. How do you greet someone? That person walks into your athletic training environment and you have to greet them. What is the first thing that you do? How do you address that person? Should you extend your hand and give a handshake? In some cultures, it would be more appropriate to bow. How do you address them? Formally or informally? Do you address them as Mr. or Ms. or Mrs.? Or do you address them by their first name? For example, in African American culture, it is more appropriate to address someone by their title. But when in doubt, ask the patient how would they like to be addressed so that you don't offend someone. Learn to pronounce names properly. It's real important to understand individuals and to be able to speak their names. Where I grew up in the South and on the East Coast, I was not real familiar with Eastern European last names. It wasn't until I moved to the Midwest that I became real familiar with ethnic white names and had to learn to pronounce them properly. And my students would give me a hard time if I didn't pronounce their names, and they helped me tremendously to do so. And I remember a patient coming in once who was from Thailand, whose name was Suttanim. Now, I don't remember to this day how to spell it, but nonetheless, I did put it phonetically in the chart so that I pronounce his name properly when he came in to see me, and therefore help him to feel comfortable in the environment. So learning to pronounce names is appropriate. Find out about your patient's degree of English proficiency and fluency, and this is both in speaking the language, in reading, and in writing. Some individuals speak English as a second language. They may be bilingual, or they may not speak English at all, depending upon their degree of fluency. So it's important for you to have that understanding. Speaking is just one way, but if your forms are written in English, and I would presume that they are, then does that individual read English well enough to understand the forms that you're giving them? It may be important to translate into a document that they would be able to read. Certainly be careful as you're translating documents that you have someone who is proficient in doing so. You don't want to translate something inappropriately for the individual. The other issue with translating information into written format is the proficiency of that individual to speak their native language and to read their native language. So the level of proficiency of what you're writing is important, or what you're translating is just as important as what you're writing in English. There are several nonverbal communication issues that you may come across that you have to deal with. The first one I want to address is gestures, and gestures do not have universal meaning. For example, when we think about beckoning someone towards us, often in American culture, we will do it with the individual finger and beckon the person, or you might use your entire hand to tell them to come here. Well, I certainly learned the hard way that can be offensive. My sister-in-law happens to be from the Philippines, and in Filipino culture, beckoning someone with the palm up is akin to putting up the middle finger and cursing someone out. So when my little niece came to me and I said, "Come here," and I did not realize why my sister-in-law had the strange look on her face that she did, because I was basically cursing out my little niece. In Filipino culture, to beckon someone towards you is done with the palm down, as you beckon someone in the manner in which I am currently demonstrating. Other gestures that we need to think about is pointing. In many cultures, pointing with the first finger is considered offensive, and people might point with the thumb, or they might use the entire hand, or pass something to you with the hands together. So understanding that is important, and realizing that gestures do not have universal meaning. Another nonverbal communication gesture, or another thing that you might see, would be smiling. And that smiling may not be indicative of friendliness. Smiling may be a way to show that someone doesn't understand what is being communicated with them. They may be shy and may be embarrassed, and so may using smiling as a way to cover up that. They may also be using smiling as a way of saving face. Saving face is something that you might see in some Asian cultural groups, where it is important for the individuals to have respect and show respect, and to not disrespect the individual or make someone embarrassed by what may be taking place. So, for example, your patient might come in, you tell them what it is that you want them to do, you give them instructions for their rehabilitation, their home exercise program, and that patient really doesn't understand the instructions that you're giving them. So they might smile and nod, as if saying, yes, I understand, but in fact they do not, and they're trying to save face and trying not to embarrass you as not being clear in your directions to them, as well as saving face that they didn't understand. So it becomes really important in that instance that you're going to want to have the patient repeat back to you what it is that you want them to do in order to clarify meaning. Another nonverbal communication issue that you may deal with is eye contact. Direct versus avoidance. Should you give someone direct eye contact or should you avoid direct eye contact? Certainly in some cultures, it is important that the people that you trust, that you respect, that you do not look them in the eye because it is disrespectful to do so. So that individual may not look at you in the eye because they respect you. I would take the lead of the patient on whether or not I should be looking them in the eye or whether or not I should not. If you're looking that person in the eye as if to say, look at me right here, and they're looking away from you and they're feeling very uncomfortable, then take a cue from your patient that you shouldn't continue to stare at them directly in the eye. Also, looking at individuals in the eye may invoke what can be called the evil eye or cast some type of negative presence around that individual. So again, take the cue from your patient on whether or not you want to use direct eye contact or avoidance. Silence. Being silent. It's sometimes difficult. We often want to jump in and say something when someone is being silent. But silence could be used as a response time. When one of your patients speaks English as a second language, that individual will hear what you're saying in English, need to translate that into their language, for example, Spanish, develop an answer in Spanish, translate the Spanish back to English, and then respond to your question. And the only thing you asked was, what happened? Let alone the rest of the evaluation of how did it happen, what was the mechanism, does it hurt, can you tell me on a scale of 1 to 10 how bad it hurts? So you need to allow for that silence, allow for that individual to respond to what it is that you're saying. Also, other cultures may need a respect for silence, that it is okay to have the silence. They may be contemplating what it is that you are saying and want to give careful consideration to their particular answers. Use the time of silence, if that is taking place with your patient, to assess their nonverbal communication. That may be a chance to look at their skin tone or other signs and symptoms that you might be able to detect while they are contemplating or in a silence mode. If you need to draw them out or feel the need, you may ask or you may indicate, I see that you are not saying as much. Is there anything you would like to share with me? Would you like to share with me your thoughts? So you may be able to draw them out. So those are ways that you may be able to handle the silence. And lastly, I want to talk about narrative sequencing, chronological versus episodic. Typically in medicine and in athletic training, we tell the story in a chronological order. This is what happened. And as we think about American culture, we think about storytelling as once upon a time. And you start at the beginning and you move to the end of the story. Every now and again, we'll pick up at the end of the story, but we won't get the very end of it. And then they'll backtrack and take you back to the beginning of the story and move you chronologically until you get to the finale. Well, some of your patients don't tell the story of their ankle injury in a chronological fashion. And indeed, the ankle injury is a story. It's a story about what happened to them along the way as they happened to sprain their ankle. So they may tell it with regard to episodes that have happened and put it into a different context. It can be really frustrating for athletic trainers, typically because we want things in a chronological fashion. What happened at the beginning, tell us about the mechanism for injury, and so forth. You don't want to disrupt the flow of the storytelling because the patient may feel that you don't care about them, that you're not listening to them. It is your responsibility as the athletic trainer to take that information, and when you document it, you certainly can document it in a chronological fashion. But to disrupt the flow of the story may show that you're disrespecting the individual, and they may not open up and continue to tell you what is going on with them. A few other considerations that you might want to take with regard to the history portion and gathering information is recognizing the importance of social and personal conversation. In some groups, African Americans, you may see this, you might see this in Latinos, where this social conversation, understanding who the person is, not just the ankle injury that walked in. Again, it's that opportunity to get to know the person may be important as you establish your relationship, as you establish rapport. We talk about that in athletic training, the importance of establishing rapport so that the patient feels comfortable with who you are. Other considerations include the social